Imagine that you knew something, or you felt in your heart that you knew something, except it seemed like nobody else knew that. Sometimes when I'm talking to MS doctors, that's kind of how I feel. In this video, I'm going to talk about why I'm in the minority oftentimes when considering treating MS, and why, honestly, I think everyone else is wrong. Don't turn away, because that starts right now. Howdy! Thanks for learning about MS with me, Boster. I'm the founder of the Boster Center for MS, where we care for families impacted by MS from around the globe. This video is truly a vlog in the respect that I'm genuinely just sharing some emotions and some thoughts that are in my head. If you look at the surroundings here, I'm on a family week vacation in the Hawking Hills in southern Ohio. It's absolutely beautiful outside. In fact, before I jump in the topic, I just want to show you my view because I really think it's awesome. So let me see if I can not mess this up. How do I flip the camera around? So it's just a really nice forested area. This is the view right off the porch here. Little fishing area, the forest I've been taking some walks in. So I just want to share with you guys. So there are 24 different disease-modifying therapies or medicines FDA approved to slow down multiple sclerosis, specifically to decrease attacks and clean up the MRI. Most of them have demonstrated ability to slow down disability progression. There's 24 different drugs. And there's a lot of neurologists treating MS around the country, around the globe, and all of these medicines are available to them. Now, here's the kicker. They're not all equal. Some of them are better than others. So some of the medicines appear to be able to decrease relapses or to decrease disability progression or to clean up new spots on the MRI way, way better than other ones. Now, these ones that seem to work better, they're not more expensive. They're not. And they're not more dangerous, because they aren't. But they are more effective. And it drives me crazy, oftentimes, that I'm considered a weirdo because I want to put someone newly diagnosed with MS on the most effective drug that they're comfortable taking. And that oftentimes might not be a first-line therapy. Again, this goes back to my gripe with the escalation model. Many MS neurologists would inappropriately say,
hey, look, I'll put them on a platform drug.
Code for low efficacy.
And if everything goes okay, then great. I'm a good doctor, they're a good patient, that's a great drug. If they have an attack, or if they, it doesn't work out, well, then I'll upgrade their drug to something that works more effectively.
Well, it doesn't work out means you allowed your patient to suffer brain damage. And they may have lost a neurological function and not fully regain it. And so if I could pick a medicine that was better at preventing that, wouldn't that make more sense? And when that medicine is not more expensive and it's not more dangerous than the medicine that you want to use, I don't understand why we'd want to use the medicine that you're suggesting. It really doesn't make sense to me. And it's actually more complicated than that, or deeper, if you will. We have to call into Scripture the concept of therapeutic lag. So the actions that you take today, taking a disease-modifying therapy for MS, the consequences of that action play out several years later. When you take an MS medicine, the benefits to the MS medicine are really seen 3, 4, 5, 8 years down the line. And so you may be taking a low efficacy medicine because your doctor gave it to you, and you may be accruing a couple new brain spots here or there, maybe a little bit of accelerated brain volume loss, maybe you've had an attack. That's brain damage. That's damaging your brain and your spinal cord. And importantly, that's setting a trajectory of disability, because your brain is at risk of aging faster from MS, getting smaller quicker, and those first several years are critical. Really, it makes so much more logical sense to hit this disease super hard up front with like an induction model or with a high efficacy therapy to quell the inflammation and help calm the brain and the spinal cord and reduce the inflammation as much as possible so that the person can have a normal life trajectory. Their brain can age naturally. My concern is During those first couple years, those first 5-7 years of the disease, when the person is suffering pathologically the most amount of inflammatory damage, they also feel the best. They also have the most functional reserve. They can rewire the fastest. They're the youngest they're going to be. And they may not know, you may not know that you're developing brain damage, that you're developing new lesions, or that your brain is accelerating at a faster rate, thinking that things are okay, and they're not. And if we fast forward 15, 20 years and look back and say, I'm so sad, I really wish that we had upped the ante back then, that's a really sad conversation to have, because we can't impact the past then. We have to make those decisions now for the future. And I don't think that doctors spend enough time talking to their patients about the long game, and about how these disease-modifying therapies do more than just stop attacks. When you look at the clinical trials data, it's really, really compelling that the earlier you start a highly effective disease-modifying therapy and the longer you stay on it, the better you do. Not just with relapses, but with quality of life measures, with cognition, with sexual function, with bladder function, things that really, really matter. Honestly, I have the same frustrations related to people impacted by MS who have had the disease for quite some time. It's not uncommon that I'll talk to someone with MS who's maybe in their late 50s, 60s, something like this, and they'll share that another doctor, another neurologist, told them, you can probably stop your medicine, you don't need it anymore. Which is freaking insane to me. That person still has an immune system, and that immune system still wants to attack their nervous system. And that person still has nervous functions they like, functions like seeing, eating, swallowing, orgasming, moving. These are things they want to maintain. And when you look at data of pulling people off their DMT, sometimes they do okay. Sometimes they progress in their disability. Sometimes they have attacks. Now, it's true that as you age, you are statistically less likely to have an MS attack. That's true. But you're also way less likely statistically to bounce back from that attack. And so you may end up with a stepwise loss of function. And we could prevent that. But again, I go back to the idea that these medicines do more than just prevent attacks. Again, when you look at long-term follow-up data, it's very clear that the longer you keep someone on a DMT, the better they do. And let's just pretend hypothetically that the effect of that disease-modifying therapy was less oomphy when you were older. So what? It still works. Maybe it doesn't work as well as it did or as robustly as it did when you were in your 20s and 30s, but if it's still providing you with protection against accelerated brain volume loss and disability and new spots and new attacks, why don't we keep that going? Maybe that's a really, really good idea. Moreover, these newer, highly effective disease-modifying therapies bring more to the table in their ability to slow disability progression, in their ability to maintain function. There was a cool study looking at the only drug approved for PPMS, that's ocrelizumab. And it was looking at people in the oratorio trial, the clinical trial we did to prove that this drug works in PPMS. And we now have 6.5-year long-term follow-up data. So the people with primary progressive MS who stayed on the drug fare way better 6.5 years later than those that were started at a delay or those that start and stopped. Again, I get confused as to why a neurologist would want a patient to come off their drug. Again, maybe thinking somehow that they're being paternalistic and the horrible side effects of the drug merit coming off, except I don't see those horrible side effects. Sometimes I'll talk to MS doctors and they say,
Well, gosh, Aaron, you would just put everyone on high efficacy therapy and not even use any of the other therapies.
what's wrong with that? Why wouldn't we want to place patients on the most effective therapies that are currently available, as long as the safety profile is appropriate? We play these pretend games where we can prognosticate and identify that this patient is not at high risk and therefore probably doesn't need a high efficacy medicine. Well, where do we get off telling them that they don't have access to a high efficacy medicine because we paternalistically told them that it wasn't that bad? And so does that mean that they're allowed to accrue a little bit of disability? We're okay with them having a little bit of brain damage, not too much, just a little. They're not deemed to merit being on something more potent. And that just doesn't sit right with me. It's 2021, and we have medicines that are better than other medicines. And I think that we should be using them. I think that we should be using the most effective drug that's currently available. Now, I predict that I will get some shade because of this little video that I'm making on my family vacation. I really do. I think that there's a majority of MS treaters that would say,
Aaron, that's not the way. We should slowly escalate. It's the right thing to do.
and I completely disagree. And I think there's increasing amounts of data supporting it. But nonetheless, I'm going to get some hate, such is life. I just want to share that this is my opinion. It's an informed, educated opinion. All right. So there's lots of areas of the world that I don't know very much about. You know, I'm not a master of mechanics or sports or politics or love. But as it relates to clinical neuroimmunology, or trying to manipulate someone's naughty immune response to stop attacking their brain and spinal cord, that's an area that I understand pretty decently, and I've spent essentially my life's work trying to combat this disease. It's something I know a lot about, and I'll take that shade that you want to throw at me, but what I would really like to do is discuss it and try to wrap my mind around why on earth you would want to allow someone the risk of getting worse on a drug that doesn't work as well when it's not cheaper and it's not safer. It just doesn't make sense. So my name's Aaron Boster, and I look forward to your comments, even the ones that I'm going to need to duck and cover for. And I'll look forward to talking to you again soon, whether it be in this forum or on a live stream, or even better yet, at the Boster Center for MS. Take care and be safe.